Thanks, Tane. Kia ora koutou, and thanks very much, Tane. And I apologise to any of you who have sat through some of these immunisation updates in the past, but I've changed it a little bit this time, and I've made it even harder. Because when I started in this game, I picked up on vaccines thinking they would be really easy. You know, you just vaccinate the kids, you send them to the practice nurse, and every year vaccines get more and more complicated. So I'm not going to help you make them easy this time round. I'm going to go through some of the complexities, particularly of the special risk groups, which I think are getting harder and harder. So my declaration of interest, I don't have any personal declaration of interest, but the Immunisation Advisory Centre does take some sponsorship for a few different things, and we have had funding for a couple of research grants listed there. So these are what I'm going to cover. And I put up a picture of a cat because they look cute, because apparently now on the internet, pictures of cute cats have got increased interest, even more than pornography now. So for some reason, you need to look for cats on the internet. So these are the areas I'm going to cover. I'm just going to touch on our biggest problems with VPD currently, which is really pertussis, flu. We're going to talk about measles. We'll touch on HPV, and then the whole vexed area of special groups, talk a bit about different vaccine types. I'm going to really then talk about private market vaccines, which I think is the other very difficult area for us currently, as to what we should be offering our patients and what our patients feel we're not offering them. And then talk a bit about the future of the schedule, and then see if we've got time for a bit of communication at the end of that. So firstly, just a brief touch on pertussis as an update. We'll all know that we came out of a very large pertussis epidemic. The numbers look like they're climbing again. Pertussis, bless its cotton socks, comes back every 3 to 5 years. But even then, our background rate of pertussis is quite high. So the message is pertussis is with us, pertussis is always with us, and we can't get rid of it, because even if you've had the disease, your immunity will wane and you can get it again. And if you've been vaccinated, your immunity will wane. So whatever we do with pertussis, it lives with us. And it lives with us a lot. Now, this is an old study that I've probably shown a few of you before, but just to remind us that if you see anybody with a chronic cough, there's a high likelihood that that'll be pertussis. So this particular study that we did in Auckland back in 2011, and this was in an inter-epidemic period, so this is when there was a low rate of pertussis in the community. Even so, chronic coughs lasting more than 2 weeks, 10% of them were evidence that they were probably pertussis related, and much higher in kids. So the more you look, the more pertussis you will find. And interestingly, I think if we start thinking about elderly and chronic coughs, we may find that we are completely missing the boat on a lot of chronic coughs in elderly may well be pertussis. So just have a high index of suspicion for pertussis, because they may have a distinctive clinical symptoms in the young kids, but for the rest of us it's just an irritating cough, and you're often very well between the cough, but it's a prolonged irritant cough. So pertussis is with us, we can't get rid of it, so what are we going to do about it? Well, our immunisation strategy is to protect young infants, because even though we all get pertussis, it's the young infants that get it severely, and it's the young infants who died. So the strategy has been vaccinate, vaccinate, vaccinate on time. So when you get the parents that roll in the door and tell you their infants are too young to be vaccinated, the reason we start at 6 weeks and we want to get the 3rd dose in by 5 months is to stop them dying of pertussis. And that if we do that, the chance of them dying of pertussis is considerably reduced. And so there is New Zealand data from Cameron Grant's study that your infants are 4 to 6 times less likely to end up in hospital if you've been vaccinated on time. So it's a nice communication message, is not to delay the vaccination. Now, having said that, even if we vaccinate our infants on time, they're not going to have decent immunisation protection until after the 3rd vaccine. So essentially, you vaccinate on time at 5 months, you're still not protected well until you're nearly 6 months of age. So the next absolute key message that we are now selling in New Zealand is vaccinate pregnant women to protect infants. And now that message hasn't got out there very well yet. Our vaccination of pregnant women is extremely low. So the important message for us, and it's tricky for us because we're not even seeing pregnant women often, is vaccinate pregnant women in the 3rd trimester of pregnancy. Now, in the last epidemic that you saw, that big curve, there were 4 infants that died who were under 2 months of age. Now, I think if we had at that stage been vaccinating pregnant women, those infants would not have died. So it certainly makes a difference. We've also got some very graphic data of the number of infants in intensive care unit, and that we would be reducing a lot of the incidence of severe pertussis if we vaccinate pregnant women. So the strategy is to vaccinate infants. The second strategy is to vaccinate pregnant women, and that is the first infant vaccination. So when I'm talking to pregnant women, I'll be saying, I'm vaccinating your infant. This is to protect the infant. And most pregnant women will readily accept a vaccination to protect their infant, whereas a lot of them will turn it down if they feel it's for their own protection. Yeah. Right, so the question from Sue is this passive immunity or active? It is passive immunity. The reason we vaccinate only in 3rd trimester is if you vaccinate earlier, the mother will get a good antibody rise, but it drops rapidly. So if you vaccinate in 3rd trimester, you will get a high antibody rise in the mother. It's passive protection to the infant. And then the infant will get very high protection, more than 90% vaccine protection, passively for the first 2 to 3 months of life. So it's passive protection to the infant. There's a spin-off effect that the mother herself is then less likely to get pertussis as well. But the main issue is the passive protection to the infant. Okay, so this is a new strategy, and it's an important strategy because we know from very good data it's effective. Yes? So the question is, if you have a baby every 2 years, do you revaccinate? The answer is yes, for the same reason that the pertussis vaccine is not very good and the antibodies wane quite fast. So you want to get high antibody levels to transplacental pass to the infant, so you vaccinate every pregnancy, and that's why you wait till 28 to 38 weeks to vaccinate. The reason they don't fund after 38 weeks is because you're likely to produce the child by then before you've given passive protection. So you get the free vaccination between 28 and 38 weeks of gestation. Okay, now I think the message for us is find pregnant women early and make sure we put them on the recall, okay, which is not what we've been doing up till now. Now the other question is, what are the gains in the other strategies? So currently we vaccinate 4-year-olds and we vaccinate 11-year-olds. The important strategies there is, firstly, it gives those children protection, but it also reduces their chance of passing it on to the younger infants. So there is some gain and important in vaccinating older children. Does cocoon protection work? This is where family members come in to protect young infants. Now, cocoon protection we still recommend, but in practice it's extremely hard to deliver well. And there's a couple of problems with it. Firstly, all family members around young children need to be vaccinated because adults will not have long-lasting immunity. So that means anyone in contact with young infants. Now, you'll probably all have people coming and asking for the vaccine. Grandparents, fathers, close contacts. Fantastic. Vaccinate. It's not funded, but I think for a thinking family it's a good thing to do. It's not as effective as vaccinating pregnant women and giving baby passive protection. That's much more effective. The problem is even a vaccinated person can still carry the pertussis. Okay, so cocoon vaccination is worth thinking about, but the reason it's not nationally funded is it's actually not as strong a strategy as the other ones. Does that make sense? So here's my summary slide for pertussis vaccination in pregnancy. There is excellent British data to show that this is highly effective. Interestingly, passive protection in pregnancy is more highly effective for the infant than our active vaccines in infancy. That's extraordinary vaccine effectiveness, over 90%. So we really got to raise the profile of pregnancy vaccination. Internationally, this is a huge shift in vaccination. You know, traditionally people avoided giving anything to pregnant women. We have now got quite a major shift. So think pregnancy now. Right, that was almost. Any other comments, questions, thoughts around whooping cough before we move on to another interesting bug? We all good on whooping cough? Yes. We can't answer that one. So the question is, as healthcare providers, how often should we vaccinate ourselves? The answer currently is every 10 years. Now, what we do know is vaccines will wane in about 4 to 6 years, and we can actually transfer pertussis even earlier than that. So 10 yearly is probably not ideal, but realistically, to get it in early, more than 10 yearly is a long ask for all of us. So we're saying 10 yearly. I think for people in very high-risk occupations, like a neonate unit, SCIBU, something like that, probably less than 10 yearly. But current international guidelines are 10 yearly.
Any Facebook side effect of pertussis?
Yeah, not pertussis. We'll get on to HPV. That's the Facebook side effect at the moment. So currently people are quite happy with pertussis. It shifts around those ones. You know, I mean, there was the old years ago argument that pertussis caused brain damage. That seems to have sort of gone away. We don't hear that one very well now. So no, pertussis at the moment is relatively flavour of the month. I don't know why. Moving on. Right, we're our next new bug, and as we know, we got flu vaccine in our fridges last week, made us all busier. So flu vaccination, does it work? Well, I don't know. You see, these guys have been vaccinated and they're still with us, so I guess that's something. I don't know. So, how effective is the vaccine? Well, we actually have New Zealand data now. So we've had the privilege to be involved in a study for the last 4 years that the American CDC has funded called SHIVERS. Are any of you guys in the SHIVERS study? No, gay tiny. So, yep, there's a few practices here. So this is data straight out of the SHIVERS study. Does the flu vaccine work? Well, the answer is yes, it does. And it varies from year to year. And if you look along, this is the overall vaccine effectiveness from 2012, 13, 14 and 15, okay? Effectiveness against ending up in hospital with flu, or effectiveness against ending up visiting the general practice with flu. And what you can see, and you see the confidence intervals are pretty wide. Overall, it's about 50% effective. Overall. Now that's lumping everybody together, okay? So overall, the flu vaccine is moderately effective, okay? It's certainly not as good as measles vaccine or as HPV or Hep B, but when you think about numbers of people having flu, you're still reducing a large amount of cases, just on a numbers game alone. So it's not a great vaccine, but flu is such a common disease that you're stopping a lot of disease, okay? So overall, I reckon it's about 50% effective. Is it different for different serotypes? So this is looking at AH1, AH3, all A's and all B's. As you can see, it really varies from year to year. I mean, one could maybe say that it might be more effective in B's. I'm not convinced. So overall, I'd say that it varies from year to year. It's around about 50% effective. But who's it more effective in and who's it less effective in? This is the whole group. But it's more effective in some groups than others. So I would say moderately effective, however you like to define about 50%, but it's much more effective in healthy children, healthy adults, and it's very effective in pregnant women, whereas it's less effective in elderly and people with comorbidities. And of course it varies if you get a seasonal mismatch. So who's most at risk of flu? The people who the vaccine is least effective for. So we've got a bit of a problem that we are vaccinating in an individual protection, and a lot of the people we're vaccinating are not likely to respond effectively to flu vaccine. Now, that doesn't mean I don't think we should be using flu vaccine. It means we've got to recognise the limitations of what we're doing. So where is disease the most severe? Disease severity is worse for pregnant women. Now, vaccination does work well in pregnant women, so that's good. But disease severity is worse in elderly and those with comorbidity and the very young, and the vaccine is less effective in that group. So what we should be doing is other strategies to protect these people, not just individual protection. Currently, the New Zealand strategy is individual protection. High-risk groups, pregnancy, people over 65 years of age. Selective immunisation of healthcare workers. How many have got their flu vaccine so far? Yeah, we're pretty good, aren't we? We're much better than the hospital workers, actually. So selective immunisation of those in contact with high-risk people. This is recommended, but it's currently not funded. Now, I think this is quite disappointing, because if you think about the fact that a very frail elderly person is not likely to respond well to the flu vaccine, what you want to do is not pass it to them. So you actually want to protect them by vaccinating all around them. So family members of high-risk people, close contacts of high-risk people, healthcare workers. So I think our current funded strategy is too limiting. All right, so I would recommend that we should be thinking much harder about protecting people by immunising around them. And interestingly, the UK now is moving towards a herd vaccination strategy. In the UK now, they're vaccinating every school child every year. And their modelling is suggesting that they're going to dramatically reduce the community spread of flu. That's likely, I believe, to be a better strategy than our current strategy. The US strategy is all people every year, and their uptake's lousy. So I think they were dreaming. So I actually suggest that I hope there's no Americans in the room that can tell me otherwise, but their strategy hasn't worked. And I'm very interested to see how the UK strategy goes. Pregnancy again. Flu vaccine works both to protect the pregnant woman who is at high risk of flu herself, and it protects the fetus because fetal outcomes are poorer with any high fever illness. So fetuses are also affected by flu, and it will protect the newborn infant. And New Zealand data shows that our young infants have got really high rates of flu, particularly Pacifica infants, infants with poor housing, and infants of areas of high deprivation. So pregnancy vaccination in this case is for the woman plus the infant. And you can vaccinate at any stage in pregnancy. It's a very effective vaccine. You'll get good passive protection to the infant, even if you vaccinate in first trimester. So once again, pregnancy vaccination at any stage. And then just touching on the herd immunity, the UK is using a live attenuated flu vaccine, which they squirt up the nose. Like that. New Zealand doesn't yet have that listed in New Zealand. It's not available or licensed here as yet. But we will watch with interest because the UK is the first country in the world to move towards a national program. There's been some other data earlier on from many countries, including Japan, showing that herd immunity can work. But this is the first real attempt in a country to see how well it will work. Their modelling data to date has suggested that this will be highly cost effective. So this is just watch this space for the future. And I think that was it for flu. So any comments or questions on flu? We're all good on flu. Yes, up the back.
Hi, my name is Gopal. Hi, it's not the flu, but I just had recently, I want to ask a question about the rubella vaccine, in a pregnant woman, so where there is no antibodies, no protection.
Okay, so I mean, obviously rubella vaccines are live attenuated, so you do not recommend giving it to a pregnant woman. Now, having said that, if it's accidentally given to a pregnant woman, there is quite good international data now that the fetus will not come to harm. If the woman has no antibodies in pregnancy, you tend to give them the advice about avoiding rubella infection in early pregnancy, which is a bit of a joke because that means any child with a spotty illness the woman will need to avoid in the first trimester, which is actually very difficult to do. But that's the general advice, is to try and avoid anything that looks like rubella. Now, one of the advantages is because New Zealand childhood immunisation rates are high now, childhood rubella is very rare. So she's sort of going to be herd protected to some extent. Then once she's had the pregnancy, then you vaccinate post-pregnancy. Does that cover the question? Great. Yes, Sue. Yeah. I wish I could say they do, but I have no evidence of that, damn it, yeah. All I can say is there's loads of flu, and you're still preventing heaps of it. That's what I keep saying. And also remembering that a lot of people will get higher than 50% protection because the elderly, the comorbidities are bringing that overall number down. So healthy young people like yourself will be 60 or 70% effective. Yes. Yep. Yep. Yes, so the question's about duration of flu vaccine. Now, once again, in a healthy person, duration of flu vaccine is probably several years, okay? So people with a healthy, strong immune system, duration's good. But where you've got people who are really at high risk, there is a question as to whether the immunity will wane earlier for the season. And if I'm really worried, seat of my pants approach, I'll actually revaccinate halfway through the season. You know, somebody who's on chemotherapy or something like that, I will actually repeat vaccination. I don't have good evidence for that. What we're hoping for is better vaccines coming along for the elderly. And in the future, there's likely to be adjuvanted vaccines and vaccines with higher antigen doses in them. So at this stage, yes, for some people it probably does wane, but we can't predict it and we don't have a good strategy for it. So once again, ring protection around them is probably the better strategy. And simple stuff like hand washing and keeping sick people and coughs and colds away from people is probably just as effective. I think if we had a much better integrated strategy, and also just reminding ourselves about our waiting rooms, that we don't spread flu to these people in our waiting rooms. So I think we also need to think much more about physical protection for these people. Yeah. Thank you. Yes. Yes, we have. And in fact, you know, it wasn't true what was said in the media last week. There was some misinformation. So the Waikato Hospital policy included people who are in frontline contact with patients, i.e. very vulnerable people, if they're not vaccinated, should wear a mask. Now, this was a Canadian strategy in several provinces of Canada, and the CEO of Waikato Hospital is Canadian, so he brought it here. Now, that was alongside easy access for healthcare workers to flu vaccination. Now, they have shown dramatic increases of healthcare provider uptake of flu vaccine. Now, I want to sell social responsibility to this country, and I do not see how somebody could be in front of a very vulnerable person and choose not to be vaccinated without a good reason. So I'm completely in support of their approach that if you don't want to have a vaccine, then you have to practice some other means of protecting your patient. So you either keep away from them, or if you're in close contact, you wear a mask. So that's the Waikato principle, and they're going to run with it again this year, and they've certainly got much higher uptake because of it. There's an ongoing discussion, is the way I'd put it. Some of the unions have. It's not a yes or a no, the answer to that. I mean, the union argument has been shifting. It was originally individual rights. Now it's shifting a bit. Yeah, well, exactly. If you start down the individual rights argument, then what are you doing? Exposing your patient, and where are their rights? So that argument is shifting at the moment, and it is a bit shifting sands. In Canada, they actually took legal advice, the unions, and lost. So the New Zealand unions aren't showing any sign of doing that. But it's a fascinating discussion that we'll watch with interest how it progresses. Yeah. Right, so the quadrivalent is available. Oh, I haven't got it here. Quadrivalent is available, so trivalent's got one strain of B and two strains of A in it. The quadrivalent's got two Bs and two As, and it's about $4 or $5 more expensive per dose on the private market. New Zealand, over the last 10 years, about 50% of the time, we've had a B mismatch from the vaccine to the circulating strain, but there's a lot of cross-protection. So how much extra gain is the quadrivalent? We actually don't know. So it's probably a small extra gain to a little bit of extra type B protection. So is it worth lock, stock and barrel all turning to the quadrivalent? I don't know. We don't have the evidence. But if somebody's got the money, there probably is small extra gain from using it. Nobody's done the head-to-heads on them, of course. That's the problem. So it's available, and if people want it, it's absolutely fine to use. I think we'll find in the next few years the whole world will move away from trivalents to quadrivalents. We're covered with flu. Great. Very quickly touching on measles, we should be able to eliminate measles locally and internationally. Measles is a disease that we should never see again. Now, New Zealand's got high immunisation coverage, so we're seeing very little measles. But historically, we had low immunisation coverage, so we still have gaps in community immunity, particularly for older children and for young adults. So remember measles, People younger than me in this room have probably never seen measles, but it does appear every now and then. Just think about it, have a high index of suspicion. And remember, it's a highly contagious disease. It's aerosolization spread, so you don't want them sitting in your GP waiting room. So if anyone appears with anything that looks like measles, do not let them go in. Just keep them in the car till you've looked at them. Don't let them walk into your waiting room, or else you'll find every patient will need to be chased down. And I think the simple rule of measles is vaccinate, vaccinate, vaccinate. There's no harm in over-vaccinating. You will not do any harm by how many doses of MMR you use. Anyone born since then needs 2 documented doses of MMR. If you were born before the moon landing, you probably had wild measles in New Zealand, okay? So anyone born since the moon landing, if you do not have documented evidence of MMR, give it to them. 2 doses. It's as simple as that, and it's fully funded. That's my summary of measles. Any comments on measles? Okay, HPV. Now, I know the session before me, they touched on HPV, so I want to make a few comments on HPV. Firstly, we're doing better, but we're not doing really very well. So we're currently, for our school-based program, for our girls overall, we're getting 3 doses of HPV, around about 60% or so, higher for Pacifica kids and lower for New Zealand European. So we're not doing very well. I don't think this is a vaccine as yet that we're selling very well. And you know what's really weird is I think it's the best vaccine I've ever seen. It's the safest vaccine I've ever seen, and it's incredibly effective. So the weird thing is this is the one that the myths are hitting in at the moment, and this is the vaccine that, like hepatitis B, it's got a fantastic safety profile. So there's a bit of an irony in that, really. I think the other thing is that the school-based program are working incredibly hard delivering HPV vaccine, and they do a great job, but the problem is that general practice is still not particularly well engaged in it. So the message for all of us now is if you've got 14-year-old girls on your enrolment base, they should all be recalled if they're unimmunised, because there's a large amount of girls out there who have not had HPV vaccine, and it's worth trying to just run through a recall on all girls when they hit 14 and offer them HPV vaccine. Now, the other important move is that the world has moved, and New Zealand has been slow, to a 2-dose regime for girls, for anybody under 15. This vaccine is really immunogenic, and the younger you are, the more immunogenic it is. So when people tell you that their young girls are too young to have HPV vaccine because they're not going to have sex till they're at least 40, what you can say is it doesn't matter. We know they're not going to have sex till they're much older, but if you have the HPV vaccine when you're younger, you get a much better immune response to it. So have it now, don't wait. Because if you wait till you're 15 or older, you will need 3 doses. Whereas if you're under 15, you can have 2 doses. Your 2 doses need to be at least 6 months apart. But I think you'll find, hopefully next year, the New Zealand school-based program will move to a 2-dose regime. And it's hopefully we'll be able to give the first dose in year 7 and the second dose in year 8. And it will make it programmatically a lot better, and also get people's heads around the fact that give it younger, it's much more immunogenic. So that's the way I hope the program will move very soon. In the meantime, for boys in the private market, anybody under 15, personally I'd say to you, WHO advises that 2 doses is good enough, 0 and 6 months. Now, this is the myth buster. If you start a myth, it gets stuck in people's minds. So I want to start by saying this is a fantastically safe vaccine. I'm not selling for the pharma company, I'm just really impressed with this vaccine. But there is 2 new myths out there on the world at the moment, and that regional pain syndromes and positional orthostatic tachycardia syndrome, POTS and CRPS, are associated with HPV vaccine. Now, you guys would have heard about this. You heard about teenagers and strange events, essentially, okay, and they're being associated with the HPV vaccine. We can find no evidence of an association, and the world is looking hard, and the world will continue to look hard, but at this stage there is no evidence of any of these unusual teenage syndromes associated with HPV vaccine. An event happening after an event does not mean cause and effect, okay? This is the problem. I think things happen to teenagers for all sorts of complex teenage years reasons. And if we vaccinate teenagers, that gets caught up with the teenage years. So personally, I think we'd be better off vaccinating kids slightly younger, where it gets less tied up with all the confusing developmental issues that go on with teenagers. So I think, speaking as having a 16-year-old at home at the moment, teenagers have their own style and approach to life. But I did want to reflect on boys. We're not meant to be showing gory pictures, but you know, it doesn't take much for a teenager to be convinced there may be a reason to have the HPV vaccine. My stepson, who's 16, says he's the only boy in the universe he knows who's been forced to have a cervical cancer vaccine. He's still speaking to me. There is a pretty compelling reason now, I believe, for why we should also be vaccinating teenage boys. Currently it's not on the national schedule, and that's purely about cost. I think it will eventually get there, but in the meantime, private market vaccines available, and if you think ahead and you can give it to boys before they're 15, you can get away with 2 doses, okay? So I think there's some pretty compelling reasons. Obviously, cervical cancer is the big numbers game, but these are there's quite a lot of these going on, and oropharyngeal cancers in men in particular are increasing. Now, I do not want to think too hard about the sexual mores about why in men they're increasing and not in women. GPs understand that, but a lot of people don't either get it. But there's a lot of HPV associated with them, okay, the Michael Douglas cancer. Any comments on HPV? Yeah. Well, you still get some protection from a single dose. I suspect it will wane though. So you really do want to try and get a second dose into them. It doesn't matter how late after the first dose it is. It doesn't matter if it's 5 years later. So I'd still be actively trying to find them for a second dose. Yes, Tane.
The HPV vaccine and the talk about changing the regime regarding cervical smear testing. I don't see any kind of information connecting those two because that's a long-term kind of...
So there's been modelling on what will happen to the cervical screening program as you have an HPV vaccination program in place. Australia, I believe, has moved to starting their screening program later. From the top of my head, I think they're starting at 25 now, and you can probably spread out so you don't have to screen so often. New Zealand hasn't got there yet, but there will be modelling, and I believe we'll move towards starting later, certainly moving towards screening for HPV, not cytology, and then spreading out your intervals so we won't have to do screening every 3 years. So that's the way New Zealand will be moving. I haven't put up any personal predictions because I think it's up to our ministry to make the decision about how we do that. And Australia is still way ahead of us on that, but it's a really good question and it will come. But of course, remembering at the moment that as we've only got 50–60% of our girls vaccinated, you've still got a lot of girls who have got much less protection out there. Anything else about HPV? So you'll hear the myths, but I don't want to perpetuate them because at this stage we're certainly looking hard at safety surveillance in HPV, and I genuinely cannot find any problems. There was a girl who died 9 months after receiving HPV vaccine. The family believes it's associated with the HPV vaccine and aluminium on the brain. There is no medical or scientific basis behind that thinking. It's very hard for the family to have a sudden death in a teenager, but it is not related to the HPV vaccine. Yeah, there's a couple of others in Europe somewhere. And of course it depends whether the countries are private market or the government schedule. So some of the countries that are fully private market recommend it. But I think Austria is vaccinating boys as well, and one other European country. I can't remember off the top of my head which. Australia's just got more money than the rest of us, I think, for vaccines, because everybody agrees it's a good idea to vaccinate boys, but it's just a straight money decision about, you know, how much disease will you prevent versus is it worth paying for the vaccine, you know. And I think Pharmac will just keep doing the cost-benefit analysis till the vaccine price matches what they think is appropriate to the reduction in cancer. The other thing, the Australians are seeing dramatic reductions in genital warts. They believe they could actually eradicate genital warts, particularly probably with the 9-valent vaccine coming. That's pretty impressive. Now, that was all the easy stuff. Oh, sorry, yeah, another one on HPV. Longevity data on HPV?
Yes.
Yeah, so how long does it last? Well, we've got data out to 10 years, which is showing there's really no sign of waning immunity up to 10 years. So, I mean, we can't answer after that, but the way it's acting, very like the hepatitis B vaccine, it's a very similar vaccine to hepatitis B. It looks like it's going to be long-acting. The worst comes to the worst, if you discover it starts to dip, you'll have to give a booster, but at this stage, it's looking like it's going to be very long-acting. The other thing we'd have to watch, of course, if we move to a 2-dose regime in the younger people, is to also watch longevity data for that, and whether you had to add in a 3rd dose if we got it wrong. Yeah, up the back.
Is there any effect on the existing wart virus that they've got with the vaccine?
Oh, other warts?
Yes.
No, well, it's only really the 4 types in Gardasil, and none of those are really particularly implicated in, hand warts and warts on the rest of the body.
So what I mean is, let's say a 16-year-old already have HPV virus on the cervix.
Yeah.
One of the 4 types.
I see what you mean.
Eradicate it?
Well, there's a couple of answers to that. Firstly is that usually it doesn't mean you've had all 4, so you'll still have effect from the other 3 types. But also sometimes you can be exposed to HPV and toss it off and not get a good immune response to it. So it's probably still worth vaccinating. And there is evidence that women post-colposcopy, there is gain in vaccination, both because they may not have been exposed to all types, but also because they may not have had their own vigorous immune response. So there is some gain, yeah. Okay, now that was the easy stuff. Now special groups, honestly, this is what does your head in, and this is what people ring our 0800 phone line. So my first answer is just remember there's a huge amount of special groups of people who could benefit from special groups vaccine, and PharmAC funds a lot of these, and they're highly complex. I mean, we all know about asplenia, but there's a whole lot of other groups where PharmAC funded vaccines to protect people. Now, you're not going to remember them all, so I want us to remember, think special groups. If you've got patients with any of these sort of issues, they may be entitled to further special group funded vaccines. Now, what I'd really like us to do is start working with our PMSs and create some algorithms so we can just go through our read codes and pull them all out, because we're missing a lot of these people at the moment. So I don't think any one of us is ever going to remember to go through each one each time. So I think we need a better systematic approach to special groups at the moment. And these are the vaccines that PharmAC funds for special groups. So HPV is available for HIV guys under 26, hepatitis A, pertussis for some groups, varicella for some groups, hepatitis B, meningococcal and pneumococcal. Okay, so there's quite a lot, and you need to look at the pharmaceutical schedule to figure out who's funded for what. So this is just one example, folks. You just pick up the paper that day and you realise one of your patients has just had a cochlear implant. Now, did everybody in the room think, aha, cochlear implant, this person should have extra vaccines? Has anyone got an idea of what sort of extra vaccines they should have? No? What's cochlear implants at risk of? Encapsulated bacterial infections. So, cochlear implants, this is just an example. These persons should have had an extra hib. They should have had a PCV13 and a 23 PPV, all of which is fully funded, and of course they get free influenza vaccine annually. Now that's one small example of a whole range of special groups that we've got out there in our GP databases that are not getting their full vaccine entitlement. It's pretty tricky. Now there's actually a lot of these ones, chemotherapy. So here's a woman who's had a mastectomy and she's on chemotherapy. She's got no other comorbidity. She comes in for a dressing. Which vaccines does she qualify for? Well, actually, it's vast. Okay? This gets really complicated. Okay, so there's a whole lot of vaccines that people on chemotherapy qualify for. Some of them you give them while they're on the chemo. Some of them give you when they've come off the chemo. So I'm not suggesting we remember all of these. I'm suggesting we remember to remember. Until we've got better systems to pull it out for us and tell us what to do, just think, is this person at higher risk? What other vaccines are available? There we go, there's the list. So everyone's going to remember this before they walk out the door, okay? Now, this list is on our IMAC website. This is how we've tried to summarise what vaccines for what particular conditions, okay? So a lot of the practice nurses are using this list quite routinely. I still think we just need to be more systematised about it. So if you're all fully taken on board all of that, because I miss most of the time. It is actually really complex. Okay, so that's the other side of special groups, is immunocompromise and what the hell it means. So we get a lot of questions like this one. So here's a lass who wants to start her training for nursing. She's only got 1 dose of MMR vaccination. It's a live attenuated vaccine. She's now on prednisone. Is she able to have another MMR? Do you know how to answer that one? Make a cup of coffee for the practice nurse. It's usually the easiest. Yeah. Okay, well, what I would say now, in the handbook now, we've got a really nice summary of the amount of immunosuppression that you can have while you can still vaccinate. So it's actually in the handbook. It's just knowing where to look for it. And that the handbook now has got a very nice chapter on special risk groups and when you can vaccinate and when you can't. Because some of the hardest ones are the rheumatoid arthritis drugs now. A lot of people on rheumatoid arthritis drugs, you want to know when you can use live attenuated vaccines. And we're getting this question more and more for the shingles vaccine. So the data is there in the immunisation handbook. And by the way, the answer to this one is? Does anyone know? Can you vaccinate this girl or not? Yeah, you can actually. If you look in the handbook and you look at the dose of prednisone you can get away with, you can vaccinate her. Okay, so that's my summary answer to special risk groups. I think we're on to. Does anyone want to make any comments or questions around special risk groups? Easy, eh? It was so easy previously. Okay, so just remember special risk groups. Now, moving on quickly, I wanted to make one comment. Vaccines are not all the same. Some vaccines are crap, some vaccines are fantastic, some vaccines are short-acting, some vaccines are long-acting. Now, the media will lump them all as if they're all the same. They're not all the same. And the one bit of technology that we all need to know about is the difference between a polysaccharide and a conjugate. And I've spent years trying to explain this to my husband. As a GP, he cannot get his head around the difference between a polysaccharide and a conjugate. He just goes to sleep on me. But polysaccharides are the old-fashioned vaccines using the polysaccharide coat for encapsulated bacteria. We're essentially talking about Hib disease, pneumococcal and meningococcal, the biggies. Now, the old-fashioned polysaccharide vaccines we've been using for ages. So the pneumococcal one is Pneumovax 23. The meningococcal ones, these are the old polysaccharides. They're not very good. Okay, they don't work in kids under 2. They don't have long-lasting effects, and you can't boost. You tend to use up your antibody supplies, and you cannot boost with them. So on the whole, polysaccharides are pretty crap. All right, the better vaccines, you attach a conjugate to your polysaccharide, you get T-cell engagement, you get a better vaccine, it's more effective in young kids, it's longer lasting, and you can boost it. So the first one off the block, of course, was Hib, which is amazing, you know, and we've pretty well eliminated Hib bacterial meningitis, epiglottitis in New Zealand. The newer pneumococcal vaccines are fantastic. The disadvantage with the pneumococcal vaccines is they've only got up to 13 serotypes, whereas the traditional one's got 23. So what we're saying with high-risk adults is you use the conjugate first, and you get good protection, and then you use the polysaccharide second. It's not as good as the conjugate, but it's got more serotypes in it. So any adult at high risk in pneumococcal disease, you go Prevnar 13 followed by Pneumovax 23. The meningococcal ones are even easier. Don't bother with the polysaccharide meningococcal unless your patient's broke and desperate. These are much better. Conjugate meningococcal vaccines are much better. You've got the ones that are against meningococcal C, or you've got the ones that are against 4 types of meningococcal disease, okay? So meningococcal, unless your patient's really broke and only wants very short-term protection for travel reasons, otherwise use conjugates. So that was my little summary about that. Does anyone want to make any comments about conjugates and polysaccharides? Because the reason for showing you that is to make sense, particularly of pneumococcal vaccines. Great. Okay, well now, the other slightly sticky issue with vaccines is private market vaccines. Now, the problem we're getting all the time is people coming and saying, my GP did not tell me this was available. And all the information you guys got out there at the moment is pharmaceutical company advertising. So what we've tried to do to help people is to produce the most boring poster in the universe. So here is the most boring poster in the universe to go through what we believe is the best evidence base for what we should be offering our patients as private market vaccines currently. All right, so these posters I've left to stack up the front. Many people are just putting them up in their waiting rooms or they're putting them in their offices to remind themselves. It's not a particularly winning, engaging poster, but it systematically goes through from infants, toddlers, adolescents, adults, people in close contact with infants, adults at greater risks of some disease, and then the occupational health, just to remember the private market vaccines. Now we're going to run out of time, so this is my little list of what I think we should be thinking about. Infants and toddlers, meningococcal C vaccines and chickenpox vaccine. Adolescents, HPV for boys, meningococcal quadrivalent vaccines because they're exposed to wider serotypes, particularly if they travel, and varicella in anybody who's non-immune. The elderly, shingles, and the 2 pneumococcal vaccines for high risk. That's the conjugate followed by the polysaccharide. High risk groups, just remember, complex and then close contacts like us. That's my little summary, and there's some posters that people are welcome to take down the front. That's the poster. Any comments on that? This is a very quick run through private market vaccines. Yeah, more and more. I mean, the more we offer it in general practice, the more people take it. It's really up to us in general practice. Still, uptake's tiny overall in terms of, until you get something on the national schedule, uptake is always low. But people want to know, they want to be offered it, and they do get very distressed if we decide they can't afford it without actually giving them the opportunity. Not that I've heard of. It's the same like with travel vaccines. I don't believe they do. I guess if you've got, does anybody know the answer to that? Yes, sorry. So pretty well, nah. Yeah, I've often used various other funds. I've even actually got some out of disability allowance forms sometimes, particularly for the high-risk elderly chronic chest when you want to get Prevnar 13, which is like a couple of $100. It's terrible. Sometimes I've actually gone to WINS offices and got them through disability allowance. So there's sort of ways around it, but it's tricky. Now, we're running out of time. What's coming next for the New Zealand schedule? What's coming very soon? Next one coming. Chickenpox vaccine. Okay, we're waiting. Pharmac's got it on a high recommendation. We're waiting for Pharmac to access the funding, and then it'll be rolled out when the ministry feels we can. So the next vaccine coming will be varicella. It will be added to the New Zealand immunisation schedule probably at 15 months of age. Now the complexity there is that means 4 injections for a toddler. So I think our recommendation is to give it separately from MMR, and that will be 4 injections. There is an MMR-V combination vaccine, but that increases the risk of febrile events post-vaccination, and in that age group it increases febrile convulsions. So our current feeling in New Zealand is to give the 2 vaccines separate in different sites so you don't increase febrile convulsions. Some people would prefer to have less injections, but I think the New Zealand decision so far is we'd rather have 4 injections and less febrile convulsions. Other countries make different calls. That's next on the schedule. Next after varicella on the schedule, Australia and the UK have both introduced shingles at the age of 70 on their schedules. So watch this space, it may well be next. And then there's my list for what will come next. I think we'll find the 2-dose regime for girls under 15 for HPV will come soon. We'll eventually get HPV for boys, and then soon we'll be switching from a 4-valent to a 9-valent vaccine, which has been designed, and it's purely about the cost of buying it now. There's changes for flu vaccines. We've talked about the quadrivalent, the live attenuated, and improved vaccines for elderly. New Zealand at some stage will have to think about introducing meningococcal vaccines. We currently have quite low rates of meningococcal C, which is why we haven't introduced it yet. There are 2 meningococcal B vaccines on the world market. They are not yet available in New Zealand. The UK has introduced Bexsero, and Australia is considering introducing it. So those are future. Now, I think we're running out of time, so I don't think we're going to cover communication issues. Have people got some other questions or comments around vaccines? Yeah. Well, if somebody's had an episode of shingles, they've just very nicely boosted their cellular immunity, so save your money would be my advice. I can't see any point whatsoever in giving shingles vaccine soon after somebody's had shingles. Nobody knows the answer to that. I don't have a clue. I've said wait at least a couple of years. The funny thing is people want shingles vaccine after they've had shingles, which is completely the wrong way round. It's like wanting HPV vaccine after you've had sex. You know, it's like... So we don't know the answer, but at least a couple of years. Up the back.
Let's say a partner of someone who just had shingles.
Yep.
Would you offer them a shingle vaccine?
It's not contagious. So the question is, would you offer the partner of somebody who's just had shingles vaccine? Eh? That's your question? It's not contagious, okay? We've all had varicella as kids. We've all got it sitting there in our anterior horn cells, and it's endogenous, probably not exogenous. So there's no, you're not going to spread shingles if you've just had it. So that partner is at the same risk as any other elderly person at the same age. So, you know, sure, they're welcome to have shingles vaccine, but so is everybody else equivalent to them. Does that make sense?
Okay, we're going to have to draw this to a close now.
So please come and take these wonderful, exciting posters that you can take back to your general practices.
Nikki, thanks a lot. Always very informative, very succinct. Thank you very much.